Thank you very much for invitation. It's not very easy to talk about retina surgery. We've seen very great presentations here on anterior segment, corneal transplantation, retina clinical and surgical as well. But my task here is to talk about retina surgery, but not only on retina surgery those days, but a resume of retinal surgery since years ago. And I'm going to start off with after doing my fellowship back in 1996 in Brazil, and then I did another fellowship in Toronto, Canada, by 1997, and then for those days, nowadays, retina surgery, the evolution, what happened before, what we did before, what we do today, what we don't do anymore, what we keep doing or not doing. So my subject is combined scleral buccal and pars plana vitrectomy as a primary procedure for pseudophakic retinal detachments. So what does this mean? If we get today most of the surgeons, they do retina surgery without a buccal or a band. I would say 240 band or a 276 buccal. Either you have normal, easy case, a retinal detachment, you only go ahead and do a buccal, that's all, or you do a vitrectomy, or you do both. The individual percentage of success for each procedure varies. If we have a great, plain, easy retinal detachment case with some subretinal fluid and macula on or off, if you don't have a PVR, it goes on very well with scleral buckling alone. But if you have a more complex case with PVR or traction, you're better off doing a vitrectomy. But in the same case, and now I'm putting into perspective not only the retina, whether it's attached or not attached, the macula on or off, but I'm including here the pseudophakic and the phakic patient. And we chose to work with the pseudophakic patients. The pseudophakic and aphakic, some patients are included in the study as well. They have a better result of doing the two procedures combined, which means scleral buccal and vitrectomy rather than only one or the other. So that's where I did my fellowship after one fellowship in Brazil. This is in Toronto Western Hospital, University of Toronto. And now our service is in Brazil at Eye Bank Foundation of Goiânia, Brazil. And at the Eye Bank Foundation, we do all sorts of ophthalmic management. We do retina, we do cornea, we have fellowships, we have residency programs, and we have, fortunately, the best stuff to go on and to practice retina surgery. And now, I'm just going to invite you to join our society. It's a Brazilian Vitreoretinal Society. We call this BREVS. And presently now, today, we are having in Vienna the American Retinal Society Specialist Meeting. And our team, the Brazilian team, is the second group, losing only for United States. We have over 1,000 members in Brazil. Some are not from Brazil, some are from the US as well. We have like Borak Cooperman, which is there. And actually, I would say he's half Brazilian, half American. And he's always joins us in our presentations, not only in these congresses, in the Brazilian congresses as well. And we invite you to take part. talking about retinal detachments, the most complex retinal detachment I'm going to talk about now in this presentation, what could be most complex would be inferior retinal detachment, because in these cases that I'm going to show you, we are comparing pseudophakic and aphakic retinal detachment patients with not complex retinal detachments. I mean, not PVR, easy cases. And then I'm going to go on and proceed with some videos showing you how we manage surgeries doing these patients with the band, scleral buckle, and comparing doing without the scleral buckle and doing vitrectomy alone. So, background and objective. Pseudophakic and aphakic retinal detachments are associated with a lower percentage of successful primary repairs with standard scleral buckling surgery than phakic retinal detachments. The objective of this study was to determine whether a combined scleral buckle and vitrectomy as a primary procedure offers any advantage over conventional scleral buckling in primary pseudophakic and aphakic retinal detachments without PVR. So we chose the patients without PVR. And actually here, you have the retinal examination. You know that the image is inverted as you use. We usually use the 20 diopter lens or the 2.2 pan-retinal. And you see in the case, in this examination, that the image gets inverted. And one of the things I'm going to show you from, I think, what we did in the past, what we do today, and some things that I do myself, I don't know if everybody does, or actually there are some procedures I do, but they're completely new that I'm going to show you during the surgeries. One of the things, I'm not going to talk on that about that exactly right now. I'm going to show you the surgeries. You're going to see that I do inverted vitrectomy. And it's not common to do inverted vitrectomy. We had, many years ago, many paper works on inverted vitrectomies, but actually they were using exactly the 20 diopter lens. You get to see the image inverted, and then you kept doing the vitrectomy with the left hand holding the lens, and with the right hand with the cutter, and you had the illumination attached into the eye. So it was very difficult to do, and there are some referrals on those papers, but people stopped doing that because it's complex. But imagine today you're doing vitrectomy, inverted vitrectomy, without an inverter. I think it's easier for some, could be easier for some, because if you go to the rationale that you are sitting in front of the patient and you are not standing up, holding the lens on the left hand. So it's comfortable, but I don't know many people that do that. So you have to examine the patient very carefully. You have this patient here as a macula-on retinal detachment. The patient is probably 20/20. You don't see the break in the retinal periphery. But if you don't see the break, if you don't examine the patient very well, unless it's serious retinal detachment, you lose the break, you do the surgery, you don't do a good work. So you're probably going to get recurrent retinal detachment later on. So this was a prospective randomized, non-randomized clinical study. 94 consecutive pseudophakic and aphakic retinal detachments were included in the study. All patients were operated upon the same surgery, myself. And now, talking about MIVS. What is new today? I already said something, what has been done before, what we don't do anymore. Why did people move to retinal surgery without a band? Does it help to do surgery, vitrectomy surgery, with a band nowadays? And some people don't do but they don't have arguments. They just say, I don't do band anymore. I don't do 240 band or 276 or whatever else. I don't know. I don't do, if I do a vitrectomy, I don't put a band because I don't need that anymore. That's not an argument. In that study, we proved, because all our patients got attached, that by doing the combined, because the combined procedure alone would be like 80, 85, 90%, depending on the case. If you have a very good retina without PVR, so it's even more to attach a percentage to attach the retina. If you do vitrectomy, in this case, you wash out all the RPE that is probably floating into the vitreous. You have the tobacco dust signs and things, and you wash out everything. So the likelihood of having a PVR gets even lower. So you make things better for your patients. So going on with the study, each patient underwent a combined scleral buccal and pars plana vitrectomy with fluorocarbon injection and air fluid exchange. Each patient was followed by the operating surgeon for a minimum of 6 months. If the patient was only seen and we could lose contact with the patient maybe 4 or 5 months, the patient was out of the study. So we kept the patient up to 6 months at least to observe whether the retina was attached or not at the end of study, and that was the end point. Before talking about dirty cycle and the modernities of nowadays vitrectomies, what I wanted to point out here is that by 1997, 1998, we already had perfluorocarbon liquids, which was a major advantage. At that time, we used mostly the 20 gauge system. I mean, the opening was 20 gauge. Today we use 23, 25, 27. But at that time, you only had 20 or even larger. But most of surgeons used 20 gauge retinal vitrectomy systems. And what was interesting is that by the time I came to Toronto in 1997, before going there, I did a fellowship in Brazil, and we had done this fellowship with so much vitrectomies and wide-angle viewing systems. At that time, people were just switching from the lender's lens that you rotate, and you see only what you're doing. You go to the periphery, you have to keep rotating the prism lens. The lender systems were widely used. But they were switching, at the time in Toronto, they were switching to the Volk system. At that time, we already had the Volk system, the AVI system, the ABLE system, the Biome system, which are widely used today. Today, it's difficult. You see, when you see a vitrectomy presentation of ophthalmology retina congress, without a wide viewing system. Almost everybody does wide-angle vitrectomy viewing systems. And by that time in Toronto, because I had done this fellowship and the people there were only kind of switching from the lenders to the wide-angle, I was able to show them my experience by that time. And so, of course, I operated with inverter into the microscope. So that's cool, everybody does that. But with time, it developed a different technique of doing surgery without inverting. But the advantage now is that I was sitting in front of the patient. When people thought it was inverted, for me it was not, because the retina was upside down. It was pretty much the same way you draw the retina on the paper. So if you were operating the right eye, the patient hears in the right eye, I can see the right eye like being drawing. The difference is that I'm coming from here, and you see the instrumentation coming upside down. So it was not easy at the beginning to control that. And so we have some concepts in modern ophthalmology, especially when we come up with better instrumentation about doing surgery, vitrectomy surgery. And one concept is the dirty cycle. So dirty cycle is an engineering term, usually expressed as a percentage ratio of time that a component is operating against the total cycle time. What does that mean? That means that when you have a good tip, a good cutter, a good retractor, and you avoid too much vitreous coming in by having a stop in the dirty cycle. You have the guillotine system from the Alcon system, for example, Novartis, and you cut the vitreous, and the vitreous come inside. By the time the opening, the cutter is open, the liquid is coming in, so it's safer if you do the core vitrectomy with that. You can control actually the dirty cycle. You don't do much traction on the retina. And if you go to the periphery, the cutter blocks. It keeps most of the time closed. It's not open all the time. So you generate less traction, and then you do a safe vitrectomy. So what it happens? The dirty cycle of a vitrectomy probe indicates the percentage of time the port is open measured against the total time of the cut cycle. The added ability to vary dirty cycle, which happens only from until I know with the cutters from Alcon, you can either choose to vary the dirty cycle doing core vitrectomy, 50-50, or shave. What does this mean? If you want to do only a core vitrectomy, you just use the cutter in the middle of the eye. So most of the time, the cutter is going to be open, and so the vitreous is going to come in. So you don't have much traction from the periphery to come, and so you are not going to generate a retinal detachment iatrogenic from a break in the periphery. Also, as well as cut speed and aspiration rate, that has enormous impact in the safety and efficacy of the new vit probes. And now, that's a graphic, it's an example of what I just said, is that the less cut if you have, for example, 1,500 cuts per minute as compared to 5,000 cuts per minute, and this is safer because most of the time you generate less traction, you remove the vitreous, but most of the time the cutter is being controlled. You can either use 50-50 core vitrectomy or shave to vary the dirty cycle. That means if you are in the center, you use, for example, the core vitrectomy. You are not going to cause traction on the periphery. You're gonna, if you are in the periphery, you can use the shave. By using the shave, you are going to remove the peripheral vitreous without causing retinal break. And so it's safer, especially in the 25, 27 gauge systems, rather than doing the 20 as compared to years ago, to do a vitrectomy with more cuts. It actually protects the retina bone from being cut in the periphery and causing iatrogenic retinal break and whatever else. It doesn't need to be in the periphery. So this is how the cutter is formed. You have the aspiration port. You have the diaphragm, return spring, pneumatic drive inlet, cutter motion, cutter port, and the cutter. These cutters, they have already, also an advantage of the port being more in the periphery, so that makes easier for you if you want to remove epiretinal membranes, for example. I'm going to show you an epiretinal membrane removal very close to the retina, but not with the port, but actually can be used with the forceps or with the cutter as well. So it made things easier with those cutters we have today. And now I have a comparison for you from the 23 gauge system and the 20 gauge system. even though you know you might still do 20-gauge vitrectomy, if you have a comparison from years ago, from 20-gauge vitrectomy in 23 or 25 or 27 vitrectomy today, that's amazing, the difference. So I'm encouraged to do only 23 or more, but I don't want to go back to my 20-gauge vitrectomy surgeries. You're going to see why. So I have here retinal detachment surgery. It's 23 gauge. And also the advantage of doing that surgery is that you have, you don't need to put a stitch at the end of the case. I rarely do a stitch. Oftentimes when I do silicone oil, I put a stitch. And now I'm showing you a 20-gauge needle, a 20-gauge system vitrectomy, which is okay if you're going to open up the conjunctiva for putting the scleral buccal. That's the rationale of the study. In the scleral buccal, as an example for our study, is the 2040 band. You see here, it's a 20-gauge system, still from manufactured from Alcon. It's still okay, but still have to open up the conjunctiva. What is the advantage of doing the scleral buccal? You have more indentation. The retina gets attached. You do laser. You have a very huge wall against the retina to protect the free retina from getting a PVR. And then here you can suture the band and it's okay, the retina gets attached. So why not very many people do scleral buckling today or even put a band? Because it's easier for you to get to do a retinal surgery, just a vitrectomy, 23, okay, that means the other patient, you keep going, but you have to think of the patient. I do, in selected cases, I put a band because the band creates a wall against, if you have to do retinotomy, for example, you're going to leave some free retina. If you don't have anything to stop it, it's going to start growing a PVR from the edge. It not always happens, but it might happen, especially in selected cases, especially in young patients that develop, have easiness to develop PVR. And so that's why I use the one in the middle here. This is a 276. This is a 240 in the middle. Usually used for vitrectomies in patients with pseudophakic and aphakic retinal detachments. I use the 240 band. That works well because you create this effect, as you saw in the previous surgery. Now, why would you open the conj of a patient doing it 23, 25, 27? Open the conj, it gets ugly. Just to put a band. I think it pays off to do that if you have selected, pre-selected cases to do that. And those cases I selected in these studies were the patients that were pseudophakic and aphakic patients that we saw, even though the retina was mobile, we saw pigments floating around the vitreous. We could prevent the retina from getting detached. Because if the retina got detached, and then we would have to go on with another surgery. So all those cases, as compared later on, we saw all patients, we saw them, the post-operative patients, they were attached. So we did not need to do other surgeries. So even though people think it's a waste of time sometimes to put a band in a patient with 23, 25 doing a pseudophakic or aphakic, actually you save time. And you are thinking of the patient. Their eye is a little red, but 2 or 3 months is okay. I don't think that's a problem. Patients were followed with respect to anatomic reattachment, visual acuity improvement, and surgical complications. Results: all eyes were anatomically reattached after a single operation. That was the thing. All demonstrated an increase in their visual acuity, and there were no complications attributable to the vitrectomy procedure. Conclusions. We conclude that such a combined approach to primary pseudophakic and aphakic retinal detachments offers significant benefits to scleral buckling alone. And also, I extend this not only to scleral buckling alone, to vitrectomy alone as well. And now I'm going to go ahead and show you my technique. It's called the MIVS, minimally invasive vitrectomy surgery, 23 gauge. I have not much experience with 25 or 27. Some colleagues of mine, Borak, Cooperman, Oshima, they all are doing 25, some 27. But in percentage in Brazil, we are doing 23, like 80%. So almost 20% is 25, and maybe 5 to 8% is 27. So this is inverted vitrectomy. It's very fun. We presented that at the Brazilian Vitreoretinal Society meeting last April in Florianópolis, Brazil. And we are showing here, we are doing the vitrectomy. We have this retinal detachment. We are coming from here, and actually we came from there, but the image is upside down. And we are doing a retinotomy now, getting the retina free floating, getting the retina more mobile. And in this case, it's not part of the study. We are just showing the inverted vitrectomy. We remove the PVR with the cutter. The cutter is very safe. You don't need to be afraid the cutter is going to cut the retina, because the rotation is so high in the constellation system, for example, you don't get the retina. And then I'm going to be using the PFO, perfluorocarbon liquid, to attach the retina and do laser. And the surgery is finished. The retina is completely attached, and we do laser 360. We like doing laser 360 even though the other half of the retina is not detached, because from our experience, oftentimes we get some PVR like reactive from the surgery we did on one side, and you get some traction, long distance traction. So it's better of protecting the retina on the other side, not giving many rows of laser, just one or two maximum. And then to keep the retina attached, we go ahead and do direct air fluid exchange. That means by the time we are putting the silicone oil in, we are removing the PFO. Now the silicone is getting inside. It's great. And just to mention, we are almost getting done. Some mentions about the evolution of the 23 through the 27 system. We have here Oshima, 2010. And his technique and his collaborators are widespread in the world, and people keep doing more and more. I myself started doing the 23 gauge since 6 years from now. And Oshima he was in Brazil last April in our Congress. And some references of papers on retinal detachment. And this is an example to finish of vitrectomy, showing the core vitrectomy with the Alcon system. And you see the double peeling. Actually, we are doing first here, we are removing the external, the upper retinal membrane, and afterwards, we go ahead and get the internal limiting membrane. So with this system, with 23-gauge system, it's so easy to grab the membrane and peel it off because it's not so mobile, so elastic, you see, and the surgery gets easier and easier. And I invite you all to go to Brazil. Next year, we're going to have the Olympics, and we always have our Vitreoretinal Society meeting. Brazil is our capital. It's a very, very beautiful. I love my city. You know, actually, I live in Goiânia, but I work in Brazil as well, and Rio de Janeiro. And I'm open for questions. And again, it's a great pleasure to be here with you. Thank you very much.